This one's me. I apologize. I wasn't quite, this is my first journal club. And so of course I put my hand up and didn't know what I was getting myself into. So I'll try to be a little bit brief. I think my case is a little bit, there's not the systemic input that the other two cases had. So it's not quite as difficult to differentiate or diagnose with this one, but I do think there were a couple things in this case that made it it was a good learning experience for me as a clinician. So I was working with a hockey team. I had a 19-year-old goalie. Anybody who knows hockey now, goalies are really long and lanky. And it was the start of the season. So I know he hadn't been on the ice like a tremendous amount. And then once training, and this is for a junior A hockey club, by the way. So it's competitive hockey. So training in the season gets pretty intense. So he was just doing kind of like, there was no injury, no contact. He just pushed off his post, felt a pop, and had pain immediately. So he's pushing from right to left, had the pain on the kind of the outside / front of his right ankle. So that's the leg he was pushing off of. So felt a pop, had pain immediately. He was able to finish the session. So going into those like Ottawa ankle rolls, like he could walk, he could do everything. He just had a lot of pain. I didn't see him right away. I was not with the team at the time. So, I had a phone conversation. I got him started on some just basic range of motion stuff. From what he was saying, I said, you might, it's kind of a weird mechanism, but you might just have kind of a classic ankle sprain, and we'll look at it in a week when I see you. I think the confounding factor is he saw a doctor in the meantime. I'm not sure if that doctor ordered an x-ray at the time or if this was later on down the road, but the doctor, based on kind of his, like where the pain showed up in some of the tests, diagnosed him with a high ankle sprain, which, kind of set us off on a different trajectory. I saw him about a week later. He could walk, like he had pain, but there wasn't a tremendous amount of swelling. When you looked at any of his stability tests, everything was pretty good. So, doing his kind of plantar flexion inversion, like looking at all the different ligaments, he really didn't like dorsiflexion, and he didn't like plantar flexion with inversion. So that's a little bit cloudy in my mind. He was missing a bit of his knee to wall. I think you guys can kind of see what I put in there. He had a stiff subtalar. He had high arches. I didn't put that in. So, like a bit more of a rigid foot. And then, so we just went to work oh, sorry. Maybe I didn't get to the point where like some of the high ankle sprain tests were negative. Sorry about that. Some of the high ankle sprain tests were negative. So he, like a lateral shear didn't bother him. And then some of the things that you would expect would make him feel better, like stabilizing his tib fib, didn't make him feel better. So he just didn't fit a clinical pattern for pretty much like an inversion sprain or a high ankle sprain, but he was really consistent in, he didn't like dorsiflexion inversion, especially. But we went back to strengthening, control. He could do over time, the pain faded. He could do everything he needed to do. He went back to being a goaltender again, exact same mechanism. Boom, pushed off the post, felt a pop, back to original pain. So at that point, we sent him off for an MRI because he just wasn't fitting a clinical picture. And then do you want me to get to I don't know, how do you want me to go? Like ask questions or?
Yep, ask some questions.
Yeah. So I don't know, does anyone have any ideas or anything that you think you would want to look at or do?
Was anybody else treating the player at the same time, Kate, or was it just you?
No. So we had we were split between clinic. It was a rural setting. So I'll say that. So within a rural setting, different practitioners could see different people. So a lot of the hockey kids would go see a chiropractor who was just doing like laser treatment on him. He didn't feel like it was helping at all. So he was receiving that type of modality as well. Didn't seem to be getting anywhere though. But like day to day, he was in it, like, he took time off. We did some non-weight bearing stuff. We gradually pushed him into getting back training. So back in the gym, he did lots of stability work, but his ankle was never unstable. Single leg task, bounding, he could do. He didn't have that feeling of giving away or instability. But it just, when he went back into his goaltending position, specifically pushing from left, or excuse me, from right to left, it got him every time.
So
Is there anything else people would want to look at with this young goaltender?
could he hop okay?
Not initially, but
Before he went back, before the second
before
pop?
he went back, before the injury, we got him, like, we basically did everything return to sport. Like, I had him doing crouching, like, on the ground, not on the ice. So, like, lateral work, bounding lateral work, he could do all of those things. He wasn't comfortable. He's like, yeah, it's not comfortable, but it was nothing like what he said of the initial injury and the days following that.
And did you brace him or strap him in case it was a high sprain that was atypical?
I did. So I did bracing for that, and it didn't help him. Eventually, once we kind of got a better picture of what was going on after imaging, we did a different type of bracing, and that did help, which I can get to in a minute. But
okay.
there is one kind of, for me, kind of missing piece in all this that I haven't addressed. So does anyone have any ideas what maybe we were missing? Or, you know, I wasn't missing it right away, but once we got putting that picture together, we were like, well, that's exactly what's going on, kind of thing.
Is he hypermobile?
He's not. No. Or he didn't seem to be, you know. So from any of his strength testing and then what he did functionally, he seems pretty good. And then just generalized hypermobility, no.
Okay.
Where did he describe the pop?
He said it was right kind of on the outside of the ankle.
Was there any weakness with like peroneal strength or pain?
Well, so initially, any of his strength testing, if it was done in neutral, he was happy. Like he was strong enough, and like there was no kind of pain driven weakness, I would say.
Okay, because I'm thinking more like peroneal and subluxation or something like that.
Yeah, maybe. Yep.
Yeah, good thought. Yeah, I was wondering that too.
Mm-hmm. Yeah.
Where was the swelling, Kate? Was it more
It was
anterior?
kind of like more anterior, a little bit lateral, but not all, you know, surrounding the malleolus that you might think with kind of your classic inversion ankle sprain.
Yeah.
So one of the things that I haven't talked about, it's in the slides a little bit, but if anyone knows the position of goaltending, you need a tremendous amount of hip internal rotation to do those positions. And he had next to none on his right leg. He had better on his left, but his hip internal rotation was not great. So really, if you think about him having to get in that crouch position and then push, it was putting a lot more force than you would think into kind of like a dorsiflexion eversion, kind of a compression going on over and over and over. So eventually, when he didn't respond the way that we would expect him to respond, based on either a high ankle sprain or an inversion sprain, eventually we sent him for an MRI, and he ended up having a subchondral lesion. So we think it was potentially like the fibular head just jamming him over and over and over. So it doesn't really explain the pop. It doesn't explain some of the things that we were seeing. But I think for me, the learning point was, one, I kind of started to just go off of what the other practitioner said. I'm like, well, right off the hop, I'm like, well, he doesn't have the right mechanism for a high ankle sprain. Like, he didn't get forced into dorsiflexion, or like there was no abrupt push. Like he said, he was just doing kind of his classic push, and that's what happened. There was no rolling in for like a plantar flexion inversion. And then some of those special tests weren't positive. So if you start to put things together clinically, it didn't really match any of those things. And then also the way that he progressed through his injury, just like he did really well in his ankle from a stability standpoint in the gym, and it just didn't transfer onto the ice. So that for me, it just taught me to listen to my gut a little bit better and not base my pathway off of what someone else has done. And I also think it was a nice moment for me to learn you need to push for imaging, especially in an athlete like this, sooner.
Yeah.
Those are my takeaways.
Yeah, I think you're right. I think it's that there's something not making sense here. Not making sense, not adding up. Someone needs to have another look, or we need to get another way of assessing this.
Mm-hmm.
I think Kate and I had a chance to talk about this just before we started, and we both said, but why the pop? Like, we still haven't figured out the pop. And that was reliable on both occasions and seemed to be for him the moment. I mean, certainly he commented on it, so it made impression on.
There could have been the peroneal involvement that was suggested, but when you test him in eversion, he wasn't sore, and we never recreated any popping or snapping with any of our tests. So we could never get the pop to come back, except for in those 2 instances where he went back to playing. He did eventually get back on the ice. We basically just started bracing him, so he just couldn't invert at all. And we did a ton of work on his hip to just give him access to that movement, and he made it back for the end of the season. So
cool. Well, thank you. So I really found these cases interesting, and I know, a lot of people weren't saying too much, and there's always a problem, I think, on Zoom being shyer than you might be in person, because I can't stare you in the eyeballs and make you open your mouth. But thank you for those who contributed. And I think, as I said, really for me, I just felt this would be a nice way to end the series. This is the last in our scheduled series so far. I think that, again, I think, Kate, you having the last case there, I think it really sort of brings back that, trust your hands, trust what the body is telling you. And then see if that intertwines nicely with the history. And again, the patients will tell us what they think are important. And if we don't capture the other unprovided answers, if we don't pull out the magic answers that would really make the difference for us, we may miss something. And so then our history and our physical exam may not match. So it's either not what we're thinking it is at all, and it is something else entirely, like an osteochondral defect or a tumor, or an inflammatory condition, or someone with a shoulder problem and all the tests are consistently inconsistent, right? We see that a lot with our patients with multidirectional instability. So there's many examples in orthopedic medicine and sports medicine where people haven't read the textbooks. And they're not giving us the right problem, but that's great. I think that's what keeps us fresh, and that's what keeps us active and keeps our brains going. So on one hand, I think sharing this kind of thing is just another extension of having shared those patients and seen those patients, and to keep our minds going. So thank you all for contributing. And Kate, I'm sorry I didn't make it really explicit. I think I realized that sometime last night, fairly late in the night, and I thought, I'm not going to message her now. So she'll realize in the email message that it is you. But thank you. Thank you for stepping up and not going, no way. It's been a treat for me to be able to sit back for this. Thank you. Thank you all. I think going forward, what I hope to do is send out a little Google thingy to sort of get everyone's opinions, feedback about the journal club. The history behind this is that we used to gather around in a tobacco and have some food, and someone would volunteer to discuss a case that maybe they're having problems with, that wasn't just a compliance problem, but the patient really was challenging, and what sort of manual techniques, what sort of exercises, should there be investigations? And it was really nice because, if the therapist had questions, then sometimes the docs would pipe in and say, well, I would have ordered a test by now. So do you want me to see the patient? We'll get a test done, just to get another piece of that information. And then over the months and the years and during the pandemic, it was like, okay, well, can we broaden our reach? And this actually goes out to a number of family physicians and other physiotherapists. And this is the first time it's been on a Thursday. We've been doing it mostly Mondays or Tuesdays, and we try and start them late so that people in clinic, if they're up to staying, at work, as it were, another hour, then they're finished with their caseload for the day and can actually join us. But, we'll send out a doodle, get some, a bit of a survey about that, the good, the bad, the indifferent, suggestions for improvement, topics, and then logistics, days of the week, timing, and so on. So look forward to hearing some feedback from you. And I'm not sure that I'll do one in August, just saying. So thanks, everybody. And we'll see you at the offices.